Bismillah Rahman Rahim. Today is 27 May 2022 and I'm giving this lecture on critical congenital heart disease presenting in the newborn age at Fatima Memorial Hospital, Lahore. So, this is a quite exhaustive presentation, but we'll try to finish it. So maybe at the end we can answer few questions as well. So this is the newborn. So let me tell you before we go with the presentation. So normally congenital heart incidence is 1% of live birth. I make it simple. Actually it is 0.6 to 0.8%. So it is 6 to 8,000 live birth. So out of, if you have 1,000 delivery in Lahore today, Lahore is a big metropolitan city. So if you have 1,000 newborn born today, there is chances 6 to 8%, 6 to 8 newborn, they have congenital heart disease. And almost, I don't know the statistics exactly in Pakistan, but with my experience working in Children's Hospital, Lahore, and seeing the burden of disease overall, I think almost 5% cases out of those, they have critical congenital heart disease, and almost 1% newborns, they have critical congenital heart disease. What does it mean? Critical congenital heart disease means you need to fix it, otherwise baby is going to expire. So maybe you can fix it medically or surgically. How you fix medically congenital heart disease? You can start. So in my presentation, the most important thing, because right now most of the audience here, they are postgraduate students, FCPS doing, and mashallah they are doing very well and they are interested in topic like these. But to understand the physiology, you need to have at least FCPS, and then this talk is more catered towards the pediatric cardiology and pediatric cardiac critical care fellows or pediatric cardiac ICU. But I would expect from my PGs, they need to know what is duct-dependent lien pulmonary blood flow and duct-dependent lien systemic blood flow. So I start with this. So if you understand only these two terms, believe me, you can manage newborn. Both newborn, they need prostaglandin. Unfortunately, which is not available. Although it is available in black market, you start with prostaglandin and you shift to the patient to Children's Hospital. I'm talking about baby who is born in Saiwal, in Okada, in Chichavatani. So this is how it works in the developed countries. And believe me, you guys have to understand, the patient who is born just now, parents, they want to do everything for that child. And I have seen, if you do something, really they are happy and they want to do more, because obviously they are doing everything for their child. So, unfortunately, prostaglandin is not available. So if I say that if some lien is duct-dependent pulmonary circulation, you guys, so you can make notes now, please, in your mobile, so that you can read later on, because I am recording this presentation, so I will not be doing on the blackboard, although initially I thought I may be doing on the blackboard. So if you have a duct-dependent pulmonary circulation, you are dealing with pulmonary atresia, tricuspid atresia, and if you have duct-dependent systemic circulation, you are dealing with hypoplastic left heart syndrome, critical aortic stenosis, and critical coarctation of aorta. So these are the 5 differential diagnoses. So you start with prostaglandin. So meaning you start prostaglandin, and in duct-dependent systemic circulation, the hallmark and prototype in pediatric is hypoplastic left heart syndrome. Although in Pakistan we are leaving these babies to die, But where I work in outside like 9-10 years, people do everything for these patients. And to let you know, in America where I work, I mean, 40% patients, they are hypoplastic left heart syndrome and pediatric cardiac ICU. And they are newborn, and they have gone through the initial palliative surgery, which is Norwood procedure. Then they come back 4 to 5 months, they do Glenn, and at 2 years they do Fontaine completion. So this is a single ventricle pathway. At least PG, they need to know what is single ventricle and what is single ventricle pathway. If someone asks you, you just answer this one. Sir, initially newborn, you in hypoplastic left heart syndrome, if surgery is offered to the parents and they opted, because most of the parents, they don't opt surgery here. But if they opted, a lot of times I have seen in Pakistan, people, they are opting for surgery. So you do palliative surgery in Norwood. So what do you do in Norwood? You guys have to read what is Norwood procedure, but you go inside and you, because left-sided structures, they are hypoplastic. So you reconstruct the aortic arch, you do the atrial septectomy, and you make one atrium. And basically, once you construct the aortic arch, because there is no LV, so the only systemic ventricle is RV. So above RV, you attach aorta, which is new aorta, and actually that is pulmonary trunk, because you transect pulmonary trunk above the RV. All right, and then you make anastomosis, and that is your systemic ventricle. And you create a systemic to pulmonary blood flow, which is Blalock-Towsing shunt. We do it modified on the right side or on the left side, depending on the anatomy, and you do atrial septectomy. So this is the basic thing. So this is how you palliate. Why I am putting a 1 minute on Norwood? Because in newborn, critical heart disease is single ventricle, is hypoplastic left heart syndrome, and you have to palliate them by doing this, by doing Norwood procedure. So we are dealing mostly patient in cardiac ICU with BT shunt after Norwood procedure. All right. So this is a newborn who just born. This is 24 hours X-ray. Baby has oxygen requirement. You did X-ray. Baby has bilateral whiteout. It is in front of you. You intubated because baby has more oxygen requirement as your NICU protocol. And now what happens? Baby has severe hypoxia. And you think about, oh, maybe my baby has critical heart disease. So what could be your differential diagnosis? Obviously, what is your first differential diagnosis when you intubated? So again, I am repeating the scenario. This is a 1-day-old child who has oxygen requirement, nasal CPAP, and then intubated and X-ray is shown. So if this is Dr. Zahid patient, what is your diagnosis? Why you are not speaking? You have to speak. Shabash. RDS. And you are ventilating respiratory distress syndrome in a newborn. Obviously, you give surfactant. And mostly these patients, they receive surfactant. But baby hypoxia is not correctable. It is giving you tough time, severe metabolic acidosis, urine is not coming, baby is shocky. And you call your cardiologist, pediatric cardiologist. Before calling, what is your differential diagnosis in this patient? So this is a question for neonatal fellow. So that is the reason I ask people, they should come, that is fine. So what is your differential diagnosis? Yeah. Okay. So I will give another hint to Usman now. So you started prostaglandin, and this baby deteriorated after starting prostaglandin. So now, what is the differential diagnosis? So this is obstructed TAPVR, and that is the MCQs for pediatric cardiology, which are doing like FCPS or American board. So if you start prostaglandin in a patient who is intubated and you are suspecting RDS, bilateral, this is pulmonary edema. Because veins, they are obstructed. All right. Why I put this scenario? This is a true pediatric cardiac surgical emergency, you have to call surgeon. Normally we put these patients ECMO if they are severely acidotic, shocky. So again I am repeating now scenario, you have a newborn, you did initial diagnosis of RDS because baby has a hypoxia, you given nasal CPAP, intubated, did X-ray, bilateral X-ray like this, fine granularity, and then with the passage of time X-ray got worse. You started prostaglandin, assume this is a duct-dependent lesion, and your patient is deteriorating. And now you call your cardiologist and they did X-ray and they came to know, oh, this is obstructed. And this is infradiaphragmatic, total anomalous pulmonary venous drainage, which need to be corrected surgically. There is no medical management. So you stop your prostaglandin, you call pediatric heart surgeon, and they are preparing to take patient maybe tomorrow or day after tomorrow. And before that, they would ask you, Abid, could you please stabilize this patient? And that's a very difficult task. Believe me, you have to sit beside the patient. You cannot leave the patient because, I mean, we not go into the detail, but you have to keep them alive till the surgeon operate tomorrow. And these patients, they have a almost 70% mortality, even in America. In Pakistan, 100% mortality. But they obviously, these babies, some mother have given birth, so the mother wants everything for their child. And I have seen these patients alive also. So not they always die. So this is really classical MCQs. So neonate with critical congenital heart disease, prenatal evaluation, initial neonatal evaluation and management. We'll go now quickly, stabilization and transport, confirmation of the diagnosis, preoperative evaluation of the non-cardiac organ system. Remember, you have to do ultrasound brain and ultrasound KUB and also chromosomes. For every patient, you diagnose congenital heart disease. Timing and type of surgery. We'll go now very, and lesion-specific management. Maybe we may not have the time, but at the end of this presentation, maybe I have like 15 slides, only congenital heart disease presenting in the newborn age. So, prenatal assessment, obstetric history is very important. Genetic evaluation, I told you, they need chromosomes. So, what are the diseases which can be associated with congenital heart disease? Excellent. What else? Excellent. What else? DeJoy syndrome, 22q11, Williams syndrome, they have pulmonary stenosis. All right? And also there is plenty of other, but maybe out of your course. But these 2, 3 you need to know. Someone can ask you in the long case. So, genetic evaluation, prenatal ultrasound, I told you, fetal echocardiography. So, you see, this is very important. 60% of cardiology admission at Children's Hospital, Philadelphia, prenatally diagnosed. You are amazed. 60%. So how good is prenatal care? I mean, now you compare. And this, my presentation is from 2010. So 49% of hypoplastic left heart syndrome admission at Children's Hospital of Wisconsin were prenatally diagnosed. So, I mean, imagine, that tells you the quality of prenatal care. So, what is prenatal assessment? Believe me, this slide is very important. Obstetrical history is important. Whether, obviously, in Pakistan we are talking of whether mother is booked or not. This is the question. This is a big first question. I mean, but you need a detailed obstetric history, genetic evaluations. I told you chromosomes is important. Prenatal ultrasound is very important. And then, obviously, if you pick some signs, you know, we have very good ultrasoundologists in Lahore. So if they tell you there is some problem, there is some garbage, you have to ask fetal echo. And you can send to Dr. Najam or Masood Sadiq. They are doing very good fetal echo. All right? So, family history of congenital heart disease. Because now the baby, if someone, normally 100% mother, they will come to you if initial child died because of congenital heart disease. She will never sit at home. She will come to you, doctor, मेरे पहले बच्चे को ये प्रश्न था, could you please help me? They always seek help because anxiety is too much for the family after first congenital heart, especially if the baby died. Even if the baby does not die, baby gone through. I have so many patients in my clinic who had surgery in Pakistan, in England or in America, they come to me as a follow-up from pediatric point of view. Family education is too much. Only one child gone through congenital heart disease surgery because they are too much educated. But you just talk to them simply and you refer to them and wherever you want to investigate them, because the risk of subsequent baby with a congenital heart disease is high. All right? Almost 2 to 5%. It depends on the type of lesion again, but that is out of this presentation. Normally I told you 6 to 8 per 1,000 live birth, but if baby has, like if someone has ASD in the previous, 2 to 4%. And hypoplastic left heart syndrome, I don't know exactly, but maybe above 10%. There is a high chance that baby can have again in this problem. And also you can offer the chronic villus sampling and amniocentesis if you are suspecting, maybe like baby is high drops, you are suspecting Turner syndrome, so that is also part of. So this is a detailed assessment, and believe me, every patient in America, in Saudi Arabia, where I work, they get this all assessment, mostly. Because, obviously, they are very meticulous. So this is the fetal echo. You can see, just to tell you, this is so what chamber it could be, this one? And what chamber this could be, and what is this chamber? So this is the LV. The relatively bigger one is RV, because you know the systemic ventricle during the fetus is mostly RV. All right? You know, because LV is relatively not doing the work. And if you see here, this is the atrial part. All right? Sorry, I said reverse. This is the LV, this is the RV. But LV is doing most of the work, and RV is relatively quiet because lungs are not expanded. All right? So once the baby came out, lungs get expanded, PVR falls, and then the RV obviously taking more part. But this is the LV. So this is the all atrium, and maybe you cannot see the atrial septum, but this is the normal fetal echo. So if you ask me, this is the right atrium, this is the left atrium. All right, this is the mitral valve. So initial evaluation and management, again going to ABC, oxygen, to saturation of 80 to 85. Oxygen is good, but not in every patient. The only one exception you can write in your notes, in a single ventricle patient, univentricular heart disease, oxygen is very injurious sometimes. So obviously congenital heart disease with cyanotic is not going to correct with the oxygen, but you never know until you do hyperoxia test or echocardiography. But obviously you will correct hypoxia until the diagnosis is there. So you have to give, but I deliberately put judicial is always question. All right. So because if the patient has single ventricle, then we're not going to go into that detail, because if you give more oxygen to single ventricle, then there is a fall in PVR and there is a steal from systemic flow, lactate will build up, there will be renal injury, and a little bit phenomena we can explain in a baby of Aisha as well. Because of the big PDA, relatively big. This patient is behaving like a relatively, not small PDA, behaving like a big PDA, and there is a VSD also. So they may have a steal phenomena, especially if they are on ventilator. Because a lot of times in ventilator, FI2 we put on and then we don't wean. Place umbilical line, prostaglandin dose I written 0.05. Normally I start with 0.03 microgram per kg per minute. Calculate the dose, tell the infusion to the nurses. And the most common side effect, if you go up, obviously if you are not getting saturation, you have to go up. But if you are going up, baby can have fever, and baby can have hypotension, or baby can have apnea. So these are the common side effects. And PG, they need to know what is the side effect of prostaglandin. These three, very important. And obviously, how you titrate? By saturation. And so again, this is very interesting. If you started prostaglandin Now, this is the lesson you can write. If you started prostaglandin because of duct-dependent pulmonary blood flow, you monitor the saturation. If you started duct-dependent pulmonary systemic circulation, you assess your prostaglandin dose by urine output, mixed venous saturation and lactate. As I told you how to assess cardiac output. All right? So, then the lactate is important, not the saturation. Even in a patient with a duct-dependent systemic circulation, we need lower saturation. And that I can explain in another lecture if you guys are interested, but it will take time. That how to balance two circulations. All right? History is important. So, complete physical with 4 extremity blood pressure, saturation pre, post ductal sat, hyperoxia test. You guys know these things, X-ray, EKG, echo. So, if you see here now, so if you have a pre-ductal saturation higher, then you suspect left-sided structure hypoplasia, which is aortic arch hypoplasia, critical AS and interrupted aortic arch, or PPHN, which you very commonly see in the newborn. If you have post-ductal saturation higher than the pre-ductal, reverse differential cyanosis, these are the difficult lesions, but transposition of great arteries, this is DTGA. There are 2 types of TGA. One is the D and the other one is LTGA, that is levo rotation. So with coarctation of aorta or TGA with interrupted aortic arch, TGA with suprasystemic pulmonary vascular resistance. So these are the differential diagnoses for a reverse differential cyanosis, where you find postductal higher than the preductal. So you go with the ABC, place line, check and administer glucose, calcium. If severe respiratory distress, shock or severe cyanosis or pulmonary hypertension, sedate, paralyze, intubate and mechanically ventilate. Pre-op lactate is important to assess the systemic circulation. Check KBG, sepsis evaluation, antibiotics. For prostaglandin, we talk about low dose, judicious use of presses, obviously dopamine or divitamine, but we prefer milrinone depending on the case. Vasopressor or vasodilator, it depends on the intensivist and what you are dealing. Mostly, if single ventricle, we try to use milrinone. But obviously, if the patient is shocked, I normally start with epinephrine. I don't use dopamine. This is relatively old. I need to correct this one. Consider use of 2 to 3%. This is again, sometimes you have to add hypoxic gas mixture. Sometimes you can read in the books, they have written, in a single ventricle, you have to give less than 21%. And then this is, you have to read in the books, why you give hypoxic, you have to give 18%. Because this is how you increase the pulmonary resistance to balance the single ventricle, the cardiac output. This is relatively difficult, but you have to ventilate them on less than 21%. Side effect, we have told, more common in premature infant, clinical deterioration if pulmonary venous obstruction present. I told you that infradiaphragmatic, now you never remember, never forget in your life. If you start prostaglandin in the newborn who has RDS and they deteriorate, suspect infradiaphragmatic obstructed TAPVR. Because there are 3 types of TAPVR. One is supracardiac, cardiac, and then there are 4 types. And then there is an infradiaphragmatic, and then there is a mixed type, TAPVR. So, if you have clinical, then think about hypoplastic left heart syndrome with the restrictive intact atrial septum, TGA with the intact ventricle septum. All these patients I have seen in cardiac ICU. And especially if you have intact septum in the TGA, they can die in utero. If you have intact septum in hypoplastic left heart syndrome or like tiny, because the blood need to mix in the atrium. There should be a common atrium, because if there is a one ventricle, it has to be. That is the reason in Norwood we go inside and take the septum out. You have to create one atrium to mix the blood, because if there is no mixing, child is going to die. So TAPVR with obstruction and apnea, hypertension. Confirmation of the diagnosis is definitely important. Echocardiography is the investigation of child. Genetics we discussed. Trisomy 13, 18, 21. Turner, DeGeorge, William syndrome patient you can have in MRCP examination. They have valvular pulmonary stenosis. All right. William, they have aortic stenosis. Noonan, they have PS. You can write these. because William, they have aortic stenosis, and even they have supravalvular aortic stenosis. And Nonan, they have right-sided lesions like pulmonary stenosis. Single gene defect, all these, I am telling you, not the book, my experience. I have seen all these pathology in cardiac ICU. So, and mostly like 30% patient, I have one study on Down syndrome in cardiac ICU in Saudi Arabia. So, I mean, we have a lot of patients of Down syndrome who come for a repair like VSD or AV canal defect in Saudi Arabia because of the cousin marriages and inter-family marriages. Heart or arm, LS1 Crevel, they present with ASD. Alagile, again PS. Alagile, they have pulmonary stenosis. LS1 Crevel also, they have ASD. Heart or arm, they have these limb abnormalities, arm. They may have feature like this skeletal abnormalities like Fanconi syndrome. Unknown causes, vectoral and charge. PG also, they need to know what is vectoral and what is charge syndrome, because this can come in the talks station. So evaluation of the other organ system, really it is important. CNS, because ischemic injury can lead to brain dysfunction, GI, neck, renal. They have almost more than 5% incidence of renal abnormalities, timing and type of surgery. Now we are going to finish this first part of this lecture. So it depends on what you are going to do. Cardiac catheterization, like I will tell you, if patient has pulmonary stenosis, critical pulmonary stenosis, especially the critical aortic stenosis, we take newborn to the cath lab and we dilate the valve. And then you have a better cardiac output. Because we have to deal, remember, we have to deal urgently patient who has left-sided obstruction. All right? Because they are going to die early. Body can tolerate hypoxia very well, and patient can be on prostaglandin for a few days. But then starting, in any case, you have to start prostaglandin. Stabilize the patient, ventilate, and take to the cath lab, and then you dilate the valve. And sometimes you have to go again, and you dilate the valve in the newborn. Then you bring the child later on for valve repair, but not in the newborn because the mortality is high. So we have seen these patients, but the most common which PG need to know, it is the atrial septostomy, Rashkind procedure. In transposition of great arteries, you send the patient, they do the balloon septostomy, and patient is fine. They send home, and then later on you bring the patient and you do arterial switch. Arterial switch is Jettini procedure. These are the old, may not be written now in the books, but these are the old names. You do Rashkind septostomy, like to open the atrium and mix the blood, and then the baby will not die, situation will improve. And then you bring the patient later on and you do corrective surgery, which is arterial switch in transposition of great arteries. You do balloon valvuloplasty as we discussed, open versus closed, palliative versus corrective, trend towards early corrective surgery even in preterm or low birth weight infants. But that's a difficult task in a small babies. They need very good ICU, very, very meticulous nursing care. And believe me, I have seen sometime you will amazed, if you operate a newborn, maybe 40 people, they are working for one patient. If a patient is on ECMO, 40 people, 25 to 40 people, they are working on one patient. So you need so much big team. If you put someone on ECMO after cardiac surgery, especially the newborn, like hypoplastic left heart syndrome, and you do Norwood. So they have a lot of resources. We are living in a, but hopefully at one day we'll do everything. And we are much better, believe me. Believe me, we are much better. Because 20 years before we were not doing, now we are repairing everything in children hospital. In Karachi as well we are doing. So we are much better. Previously when I was intern in Aga Khan, we were sending patient to the India. Now we are not doing, we are repairing everything here. So we are much better. Maybe down the line 20 years we are much better, inshallah. So this is how you care patient. And this is again my topic, post-operative care in cardiac ICU. Now we finish. We start maybe later on the next month this presentation. I think we have done half of the presentation. So in the next few slides, I talk about post-operative care. What is the normal convalescence? Normal convalescence means if you operate anyone, how they go quickly out of the cardiac ICU. and post-operative uncomplicated case, and then what are the complicated cases and what are the complications after pediatric cardiac surgery. Suppose if you repair some patient like coarctation and baby you cannot extubate. So there are two possibilities. Maybe baby has a diaphragmatic palsy, or maybe baby have recurrent laryngeal nerve problem mostly. So there are other complications like chylothorax, post-coarctectomy syndrome after coarctation repair, post-cardiotomy syndrome after surgery, and there is a lot of complication after cardiac surgery, individual even system-wise. We'll discuss briefly in our next presentation, and also we'll tell you what is normal convalescence. Normal convalescence means how you take care normally these patients, and believe me, normal these first two nurses they do in cardiac surgery ICU. The people who are working even the nursing assistant in Pakistan or in developing world, because I went across the world. I went to Libya, I went to Yemen, I went to Egypt for cardiac surgery ICU missions. You go free these patients. So I have seen people, they have done repeated things, the same thing. If you do same thing repeatedly, you are expert. And that is subspecialty. And if you train nursing assistant nurses, they perform better than doctors because they are doing again and again the same thing. So lot of times, even in 10-bed ICU, there is only one doctor. And there are 10 nurses. There can be 11 nurses. One is the one who is coordinating, supervising everyone. So, it's a nursing era as well as the ICU is concerned. We don't have so much good nursing, and that is the reason, even with good intensivists, we could not perform better. Because doctor just need in the ICU only if you want to re-intubate, if you want to put a chest drain, or if you want central line or arterial line again. Mostly these patients, they have already these in place once they come back from the OR. So nurses, they troubleshoot, they do good work, they are very dedicated, especially who are working in cardiac ICU. Even if you go to Children's Hospital Lahore, Usman, you find best nurses in Pakistan in Children's Hospital Lahore. And they will make sense. Remember, this is my last statement in this lecture. If you are making sense, cardiac ICU is all hemodynamic monitoring, troubleshooting, standing at the bedside. And if you ask me कि मैंने कितना किया है, तो मैंने बहुत किया, 2004 से लेकर 18 तक किया. कितने साल बनते हैं? 16. कितने बनते हैं? तो and work in almost 5-6 units. तो लोग बड़ा अच्छा काम करते हैं. They do very nice work. We are deficient, and hopefully we'll try to make it better. ऐसा ही है? Yes. Why not? And again, I am telling you, the family who has congenital heart disease, they want to do everything for their child. I have a patient I diagnosed. They took to the Boston children. Here they got surgery and they have, some